Okay, everyone, welcome to the FRCS Mentor Wednesday session again. Today I'm quite excited because we're going to try something a little bit different. Walid is going to give us an algorithmic approach to spotter cases in the FRCS lower limb today. Hopefully we'll have an upper limb session as well in April, but I'm really excited because this is an interactive session in a different format. So we're looking forward to seeing how this goes. And it is quite dependent on you guys interacting with us. So please do volunteer. I'd like to introduce Walid Baghdadi, who's going to present this talk, the algorithm for spotter cases for the FRCS. Thank you so much.
Good evening, everyone. My name is Walid Tawfiq. I'm today trying to simplify something that I find very essential for the exam. As you can see from the topic title, it's an algorithmic approach for FRCS cases. And just from the first slide, I need you to just focus on this important thing that's called the process. Okay, not my name. My name is not that important. I think the picture on the side of the screen is much more important. And hopefully along the cases which we are going to run, we'll run it in the same pathway. First of all, I have to do acknowledgement. Shwan, who is our mentor since a long time, and in the same time, he's someone who is running free of charge this group. As far as I know, from 2016, when it was on WhatsApp, then shifted to Telegram. Mr. Jahangir Mahalakshmivala, who is a consultant lower limb surgeon in Prince Alexander Hospital. I spent with him for 2 years. He was doing an evening session teaching after his lower limb list, and you can imagine if someone doing a list like that, how much he's keen. And sometimes he used to spend up to 11 p.m. doing teaching. And Islam Mubarak, who actually provided a very unique face-to-face teaching session during my exam. So first of all, I just need to, what is algorithm? Algorithm this is a definition from Google and some reference book and Wikipedia. It's a process of a set of rules to be followed in a problem-solving operations. And the two buzzwords here in this statement, or the two important words in this statement, is a process and problem-solving operations. And that's actually the exam part 2, which you can see in front of you. First of all, you have a problem in a setting, and this problem can be a scenario, an image, or a photo. You apply algorithm by asking questions or clarifying some facts. You will be given more information. Then you will refine your algorithm, and essentially then you give options for problem solving. Like, for example, this is a straightforward example. You have a lytic lesion in the proximal femur that can be broken femur or non-broken femur. So you will apply algorithm by this lytic lesion. Then you will be given more information as long as you are asking a relevant questions. Then you refine your algorithm, and then you will find your algorithm for example, for a single bone lesion of unknown origin, and then you can sort out the problem. So preparation resources exam, and this is something that you may find why we struggle with the exam, or why the exam have this bad reputation. Actually, the resources and the real life or the exam scenarios maybe have some sort of discrepancy. Ideally, if you are training to do a job, you should have a training on the skills that's necessary for this job. In the ideal world, you need a resources that fulfill the exam and real life needs. In real life or exam scenario, the start will be the problem and the end will be the treatment or treatment principles, not necessarily you. And that's a very, very essential principle. If you are giving a treatment to a case, you will find all the cases which we'll expose today. You see the general principles of treatment include 1, 2, 3. I'm working in the DGH district hospital. Most of cases we manage as it's as simple, but we have South Mead Hospital in my area in Somerset, South Mead Major Trauma Center, Bristol Rural Infirmary for limb reconstruction, Musgrove Park Hospital for spine cases. We have Birmingham Referral Royal Hospital in Birmingham for tumor cases. I mentioned now 5 hospitals. We don't manage any cases. We refer to this hospital if they need. In real life or exam scenario, it is exactly like mathematics. You have input, like this scenario, this picture, this photo, this X-ray. Then you will give some sort of process, and this starts simply, very generalized process. Then you will have output from the examiner or from the referral doctor in real life, or from the ED, or for documentation, or for the image result. Then you will do reprocessing. And in this situation, you need training and the problem solving practice. Problem solving practice, this is very, very essential word which I'm talking about, because the books which we have or the resources which we have, unfortunately, you don't have this kind of too much practice like we did in part 1. Part 2 is usually you have a book that have a topic like AVN, budget disease, Enkes bond, some stuff like that. And you don't have this problem solving. And when you come to the exam, you discover that the exam is all about problem solving. And then you get, this is a shock which you have, because you start a process of thinking. And if you think about whoever of us have studied mathematics or algebra or dynamics, statics in his secondary school, you will find 2 pages only that's explaining the general rules of the law. And then you find 20 pages, problem solving. Each problem have an extra addition. That's why when you go to the exam, you find the exam is pretty straightforward, because you already trained for that. And that's really, really essential in understanding the situation. Narration is one of the skills required for the exam, not all. So I will be lying if I said that today I will tell you the secrets of the exam. That's absolutely wrong. I will give you just one part of the skills that's required for the exam. So what is the skill that's required? Skill for description. You have to be able to do some sort of description. English, most I think of the participant is 30 plus or 40 plus. English is not our first language. So if you imagine yourself can describe straight away on the spot, that's something maybe a bit tricky. You can definitely, but if you have some sort of structured word to say in this situation, like latic, sclerotic, advanced cortical thinning, some sort of that, to describe a photograph, image, a clinical test, because this is the first shock will the examiner will face you. Second stage is the narration of algorithm or part of algorithm. This is process. You can go from step by step saying the things according to the question. And this is usually, that's very relevant to this talk. And the skill of answering fine detailed question in a brief, well-organized, structured way. For example, I can ask you how to manage this patient. Then you start to say, I'll take history, examination, investigation, things like that. But I can stop you to say, why do you think this patient may have pain from his first metatarsal? Yeah, that pain can originate from infection, trauma, tumor, arthritic changes, things like that. So you have some sort of, you can be asked a fine answer question, or you can have some sort of narration and the examiner just listen to your way of telling things. Then you need the skill of layman language for history. As we can see that some in the examination, in the exams, they ask you, what are you going to tell the patient? How you are going to ask the patient? If you try to formulate a question on the spot, it may be a bit tricky, especially under the heat of the exam. So you need to know, and I have to say, that's something I learned from Mr. Mahalakshmivala when he gives the Oxford knee score and the hip score in his talks and teaching, what to ask the patient, the specific language that the patient answer a specific answer for the question. Then you need to have the stamina to come across 6 cases in 30 minutes, which is 1 table in success. Okay, this is now 557 days, I think, is remaining for the exam. What should I do now? So this is a question, and you will find different answers. You have a 57 days. So someone may tell you, close the book and do some practice. Someone say to attend courses. Someone may tell you, read the book many times. You may find someone who advises for webinars. Someone may say to you, just volunteer to hot seats and be grilled. And that's my advice at the time being, try to get a processed text for decision making. And the processed text is the text that can sort out a problem like algorithm exactly. So you need to ask a problem. Now I'm reading, for example, a book, I'm reading a chapter about AVN femoral head. So you need to ask, how can I treat a patient with a femoral head avascular necrosis? What stage will patient be presented? What is the patient background? So you ask, you study not just reading, you're doing an active part to extract a problem solving from the text. Second thing, you prepare and rephrase. And the word rephrase, I got it from Mr. Mahalik Shimavala. He said that, you need to, when you have a complex text, English text or paragraph, just to try to simplify it in certain 5-10 words that have a meaning, and you can rephrase it and you can say it in a very simple way. Then you need to have the process. Once you have the process, the input which you will have from the examiner, you can analyze, and then you can answer the question. At this stage, once you come to that, that is the material you need to practice and practice and practice, and the challenge and be challenged and sit in scenarios and have whatever you like to do. Okay, the algorithm approach, don't expect yourself every single case algorithm you will be in the exam aware of it. Some cases, most of you know algorithm from A to Z. This is spot diagnosis cases. You see a DDH case, or sorry, this adult dysplasia, as an adult hip dysplasia with arthritic changes, patient need a THR, you will just go straight away with the algorithm. Unfortunately, this is not the case in all cases, but most of the exams, hopefully you will find that, and your mind will be in the certain degree of between relaxed and in paying attention, so you won't be so much exhausted. However, you will find other cases you have a certain degree of some degrees of differential diagnosis, like for example, normal looking hip X-ray. You find a patient attended to your clinic, have a hip pain, then you need to set an algorithm because this is X-ray looks normal. So it says there will be never normal X-ray in the exam, but then you will discuss, after you ask questions, the case may be a normal X-ray hip, but this patient had a metastatic lesion that will appear on the MRI scan when you scan it, or the patient had impingement, patient had AVN early stages, or patient have stress fracture. All this normal appearing X-ray, you will ask relevant questions, then you will be given straight away when you come to the point, the diagnosis, then you will come through across that process of treatment. Or you maybe see a picture that you don't have any clue about what is that, then you will apply, you will describe what you see, and then you will apply general rules. Okay, so that's the first part of the talk, which is all on PowerPoint presentation. The second part of the talk is that one which I like to show. I find at most stages that PowerPoint presentation, you may find it a bit what's called you find some sort of cut of thoughts when you transfer from slides to slides, and occasionally when I find this transfer, I find the interruption of the thought process. That's why you find an enjoying a presentation, but unfortunately it is still cut in pieces, and that's something that's I would prefer some sort of exposure like that. You read something from the screen, and I would like, if anyone on the screen now, if you have a big screen, don't use your mobile to listen to presentation, because you will lose a part of whatever on the screen. So use some sort of big screens. So first of all, when you have this problem in the exam, so you have a clinical photograph, you have an image, you have a clinical scenario, then you have a setting. Okay, you have a setting. This setting you need to pay attention. And as I said, one of the advices that I received from Abdullah Hanoun, I don't know if he's here today or not, one of the advices I received from him, you will have a pencil in the exam, you will have multiple papers, try to scrap very quickly something about what you are hearing. Just a tiny, as you are receiving a call from SHO or referral from other specialty, because you will use that at some stage. He's not giving it for haphazard. So that's the thing. So the first, you know, the setting, you know, this is a first step. You describe this photograph, or you describe the image, or you describe ask a question about scenarios. Then you give a diagnosis or differential diagnosis. It can be a spot diagnosis, like a patient who is a contracted second finger, so this is a debutant disease, or multiple asymmetrical polyarthropathy with hand and feet. This is a inflammatory arthropathy. If the patient you know this case and have a concern to straight away to say, I'm concerned about the skin condition, I'm concerned about the life limb threatening condition, I need to do ATLS. So you give a concern, Then you say some sort of differential diagnosis. Differential diagnosis can be either etiological, like almost all the time, Shwan say, return back to your basics, congenital, inflammatory, infection, neoplastic, neurogenic, if you have no idea what is that. Or maybe anatomical, like I show you a swelling on the medial side of the knee. What is that? Yeah, it can be this is swelling on the medial side of the knee. Skin is intact, can be from the skin, subcutaneous, medial meniscus, capsule, bone, and this like that. The skill which you need the exam is describing the image. You try to preserve 4 or 5 words for description. And then you need the layman language question, which if you have been asked in the exam, straight away say it. So after you describe, you give the diagnosis, you give differential diagnosis, you go straight away to assessment of history, examination, investigation. History, that is the point which you need to focus on. History of the visit complaint. I will do Oxford Hip score, Oxford knee score. I will assess the ankle, past joint history, infection, inflammation, injury, trauma, surgery, outcome, duration, indication, perioperative period, other joint history, and the medical background, including smoking. Examination, very simple. I will look general and local. Local, I'm looking for either to go by stand, walk, sit, lie. Some people are very clever in that. So you say, imagine the patient is a clinic. I will stand the patient looking at alignment, swelling, walk the patient for thrust, sit, walk, lie, supine, prone, or you go for feel, look, feel, move. Then you go for investigation, and you finish with treatment. Any treatment, as we mentioned last time, you go through this process. So like my aim of treatment is to what you are achieving. My guidelines or evidence is 1, 2, 3. The general principles, like this is a complex case or this is a multidisciplinary approach. However, the options include assuming that non-operative is exhausted, the patient is symptomatic enough, fit enough to go ahead for surgery, I will offer the operative treatment. The operative, what intervention? I will do a hybrid total hip replacement with stomach and poly, or for example, the outcome of that intervention, satisfaction rate or complication rate. Then this is very essential part because most cases in the exam is like that. Cases that is not straightforward. Why should I stop and think? Why is this case specifically come to the exam or come to the real life? And then you recognize there is a pre-operative challenges, including anesthetic or senior colleague or other specialties. Other specialties can be, again, give you a patient with a renal failure, a patient who in dialysis, so I need a renal physician, and I need to look after the antibiotics and the antibiotic instrument. A patient who had sickle cell anemia or hemophilia or thing, and I have no idea about what is sickle cell anemia can do for this case, so I'll ask the hematologist. Patient with a mechanical heart valve, I need to ask about warfarin things. So other specialties, this is your friend, and always they said to us, you are allowed to ask questions and receive answers. Intraoperative divided exposure, one side of the joint, other side of the joint. So for example, if I'm talking about hip replacement, I will do exposure, talking about sciatic nerve. Acetabular side, I will do 1, 2, 3, 4. Femoral side, my concern, this is deformity, sclerotic bone, bleeding, whatever. Post-operative, I think about complications, immediate, early, and late. That's a very, very generic algorithm. Then I will start with a case, for example, like this case, for example. One case I will... is Shwan is around? Or anyone?
Yes, sorry, hi.
Hi, Shwan, how are you? So let's see, we are talking now for almost 20 minutes. So let's invite someone, have a look at this X-ray. Let's look at this man. He had a left hip pain. He's 59.
I think Kareem Khalil had his hands up as volunteering from the beginning, Shwan.
Yes, brilliant. So that would be great. Kareem, if you could...
Here I am, yeah.
There you are. Just bear with me. I'm just going to change. There we go. Okay, Kareem, what do you see here?
These are clinical and radiographs of an old man, an adult skeletally mature patient. On the clinical photograph, I can see there is a marked bowing of both legs. This is the most obvious deformity. And on the X-ray, I can see mosaic or patchy alternating sclerotic and lytic lesions of the hips, more on the left side. Then I have to take some relevant history regarding the complaint.
Okay. What would you like to know?
His presenting complaint, for how long has he been suffering from this pain? Is it increasing or decreasing, interfering with his daily activities, or any relieving factors?
Forgive me, Walid, if you want to intervene.
No, you carry on, Shwan.
So when we were talking about the format, Kareem, the algorithmic format, you described what you saw. Do you think you have a diagnosis straight away?
Yeah, my total differentials would be a Paget disease.
Okay, excellent.
Yeah.
So if you thought this is Paget's disease, why did you not state it at the beginning?
Yeah, mistake, sorry.
Based on the algorithm. I'm not saying you must follow this pathway. Walid is suggesting a pathway to help you with cases where you know the diagnosis, or you're not sure and you've got a differential list, or you're not sure and you're going to try and work it out based on asking the history and so on. So, okay, so we know this is Paget's disease. So now you can target your questions specifically to Paget's disease.
Yes, if his presenting complaint is pain, for how long has he been suffering from it? Is it increasing or decreasing? Is any accompanying red flags in the last few months, like loss of weight, night fever, that might make me think about malignant change? Any accompanying
Is night sweats associated with malignant change?
Sorry?
Night sweats associated with malignant change?
Not always, but if he has got some red flags, this might make me think about these changes, especially with old ages.
Okay. Okay, so you, history-wise, pain is progressing. Oh, sorry, Walid, please go ahead now.
Yeah, so that's a good, Kareem. That's very good. You spot it straight away. However, you remember that something is very essential in the exam. It's a 5-minute table, and you need to come across to show that you can how to recognize the complexity of the situation. So I agree with you completely. I will start with describing. This is a clinic setting, okay? So I will start with describing, saying this patient X-ray, and then you remember for yourself certain word is cortical thickening, acetabular obtuse is not obtuse in this patient, loss of corticomedullary differentiation, coarse trabeculation, femoral deformity. Okay, so that's the word you need. So you describe the X-ray. However, I have now concern about my top of differential diagnosis is a Paget disease. Other differential diagnosis for is increased disorganized bone turnover, osteoitis dysplasia, multiple myeloma, osteopetrosis, and fibrocystic bone secondaries. Okay, then I need to do my assessment. I will say to the examiner straight away, don't stop with the examiner after a single it's increasing or decreasing. If it is decreasing, why is the patient come to the clinic? The patient may not come to the clinic. He's asking you to show you to ask you how is you are going to manage that operatively. So I will ask about the present complaint, include ensuring the pain originating from the hip joint. When you say this word, and I learned this word from a consultant working with us, when you say I'm examining to ensure the pain originating from the knee joint, you subconsciously saying to him, I'm excluding radiating pain from the hip, referred pain from the spine, or radicular pain from the nerve. Okay, so you say it in a very simple English way, ensuring the pain originating from the hip joint, because we know that the sources of pain around the hip joint can be stress fracture, malignant transformation, or arthritic changes, or spinal stenosis that's with entrapment over the nerve. Okay, so ensuring the pain originating from the hip joint, history of red flags suggested serious pathology, and that's just a single word you say. So you are excluding red flags. I will do a Oxford hip score, which all of us do that in hip clinics. You sit with the patient asking about stairs, down, up, tying shoes, going in, out of car, sitting for how long, night pain, all of this kind of question. What treatment, what received? I will ask about past hip history. I will ask about other joint history and the past medical history, including Paget disease itself, with skeletal and extraskeletal manifestation. What treatment received? What's comorbidities and medication? Okay, then I will proceed for examination. General looking for observation is not so much relevant here because this is a clinic setting. No, none of us or most of us doesn't do any observation in the clinic. I will still look for deformities. They're doing a Trendelenburg test for abductor function, check for fixed flexion deformity, range of movement, limb length discrepancy, and I will examine the hip and spine, the knee and spine. I will do imaging, including plain radiographs. So after each section, you stop to take some input from the examiner. So I will ask about history, all this in one shot. In 30 seconds, I will ask that, and then I will listen to the examiner. He will say to me, yeah, he had a red flags, he had non-arthritic pain, he had something like that. He might need to discuss some sort of safety question. Then my treatment, aim of treatment, I need to obtain a pain-free mobile hip with center of rotation restoration guidelines. If you have the patient had Botulio, you can put this paper in Botulio. If not, you just say the principle is a complex case and we need a multidisciplinary approach. Assuming the patient exhausts the non-operative treatment, I will do a hybrid hip replacement for him. However, this is an example of a complex case. The anesthetic review, I need 1, 2, 3, 4 senior hip surgeon to review because the complexity, higher risk of aseptic loosening. Other specialties, I need to refer the patient to rheumatology because he might need optimization by bisphosphonate prior to the surgery to decrease intraoperative bleeding and heterotopic ossification. Intraoperative exposure, I will talk about the sciatic nerve. Acetabular side, I will say that. Femoral side, I will do deformities. And always talk about CT scanning when you are doing a preoperative templating for such cases. Postoperative, routine postoperative care, rehabilitation, according to and giving HO prophylaxis. Okay, so that is the way you just through it. When you have this structure in your mind and just keep practice it, keep practice the structure, keep practice the structure, what's going to happen? It will very, very second nature in your mind that I'm describing, giving differentials, and then I will go for history, examination, investigation, treatment options, and complexity. Okay, so that's the first type of questions that can be asked in the exam. The second type of questions, that's kind of short question. He can ask you, what's Paget disease? What is the common, how do you know that there is a sarcomatous change? And I'll just focus on something here. It's very brief, very brief. When you see, for example, like Paget disease in a book like, for example, because someone asked me last time about this question. So this is Miller book. This is Miller. When you look at Paget disease in Miller, it is written, it's like hard fact about how do you know this is a sarcomatous change. But the thought process, if you keep reading Miller 10 times, I'm not sure it's going to generate this kind of thought process because Miller doesn't put a process, he put hard fact. You may agree or disagree with that, but that's my personal opinion about that book. Okay, and definitely you need to know how to do it. This is a generic, this is Paget disease. I will put another case like this one example. For example, this is a patient and I will need Shuan to suggest someone. This is an example how to apply hip generic algorithm to sort out problem. This patient 49 attended to our clinic. He was on the consultant side, not my side. He had a right hip pain. Okay.
Okay. So Rami Sharif is next.
Imagine you see this patient now in your clinic. Rami,
if you could kindly unmute and turn on your video.
Yeah, I'm here.
Thank you.
Do you hear me now?
Yeah, we can. Thank you. Go ahead.
Thank you very much. Shall I start or?
Yes, please do.
so this is a 40, I don't know if I say it's 40, he's 46. He attended to your clinic with right hip pain. Okay.
Yeah. So this is AB radiograph of a skeletally mature patient pelvis and both hips. It shows on the right side a deformity of the proximal femur. There is shortening of the femoral neck. There is bone in bone of the hip joint. There is no apparent, there is no evidence of metal work around the hip joint. This is advanced osteoarthritis of the hip joint with deformed hip. This is an example of complex hip osteoarthritis I would like to know more about the patient's symptoms. Has he had any history of fall or trauma? Has he had any surgery for it? And I would like also to take a history about the Oxford hip score. Was it done in the GB surgery before referring the patient to the clinic today? And I would like to take a post medical history looking for diabetes, rheumatoid disease. I would like to take a social history about smoking, alcohol intake, and his job and his limitation and expectation from the visit today.
Good, very good. So he's 46. He's struggling with right hip pain for the last 6 years, but he's managing that. And he's non-smoker, doesn't drink alcohol. He had no past medical history. He denies any history of trauma, but when he was at around 10, 11, he had some sort of problem in his hip, which he doesn't remember, and it is painful since then.
Thank you very much. I would like to proceed with the examination. I would like to examine the leg length, looking for any leg length discrepancy. I would like to examine the hip joint, looking for range of motion, flexion deformity by doing Thomas test. I would like to examine hip joint above, like the spine, looking for any deformities. Examine joint below, is the knee joint, looking for any flexion deformity or any abnormalities. Then I would proceed for further investigation in the form of the CT scan, looking for bone stock to plan my surgery.
Okay. Rami, you're doing well, very well. A couple of points I want to make out.
Yes, please.
You're demonstrating you can deal with an arthritis in the hip, but you haven't demonstrated higher order thinking in the way you've described what you're going to do.
Yeah.
Yet you are correct, you're going to assess leg length discrepancy. But why are you going to assess leg length discrepancy in this patient? Because you can see the x-ray, there is going to be leg length discrepancy, isn't that correct? So what you're trying to establish with your leg length, and a better way of phrasing that, for example, is I would assess leg length discrepancy to confirm that the difference in the leg length is in the intertrochanteric area, as opposed to there is something else going on distally. Does that make sense? Because then that's demonstrating you're thinking that if he has a deformity up here, is there a problem down there?
Yes.
And if he's had something going on with his hip when he was 10 years old, what were the things? Was it a trauma? Was it a road traffic accident? Or was it a Sufi, which is more consistent with this picture? Does that make sense?
Yeah, brilliant advice. Thank you very much.
Okay. So you did really well, but the way I would phrase it is you've used the algorithm really well, but didn't interpret it to demonstrate the 7 as opposed to the 6. You could have got a 7 out of this.
Perfect. Thank you very much.
Walid? Sorry.
Yeah, So Rami, is that right?
Yeah, Rami, yeah.
Yeah, good. That's a good, Rami. I think you did really well. But just before you embark on CT scan, ask on a lateral view for lymphedema if you are embark on something like that. And if I asked you, what do you think about this hip replacement? Okay.
Yeah, this is an example, complex hip. Yeah. This is an example of complex hip replacement. Ideally should be discussed in MDT meeting with a senior arthroplasty surgeon to discuss the options of treatment. There are many challenges I would like to go through. Shall I continue talk or?
Yeah, carry on for another 2 minutes. Yeah.
Okay, I'm concerned about the leg length discrepancy. If I'm going to lengthen in the proximal femur, there is a risk of sciatic nerve stretch. I'm concerned about the level of constraint and the abductor function. I may need high constraint hip replacement to avoid any future dislocation. I may need to cut inside.
Hope he's 46. Do you hear me, Rami?
Yeah.
He's 46.
Yes, I'm thinking about like a modular implant to give me a freedom to choose the version of the hip replacement. So I'm not going to do any cemented hip replacement. It will be uncemented because of his age.
Again, this is, look. So Rami, you were going very well, but just be careful about certain things. First of all, I have never seen some sort of constrained implant in 46 unless the patient had some sort of severe neurological deficit, or usually they go for, if the patient with a mental issues like this mental retardation, or sorry, not mental, like special needs, they will do some sort of dual mobility in this age group. So not constraining, okay? Dual mobility increase the safe range of movement, on contrary to the decrease the unsafe range of movement. This is the first thing. Second thing, if you say uncemented, you work in the UK, is that right?
Yes.
So you know that most of the trends now going to the cemented implant towards the femoral side. Is that right? So uncemented.
Not before 75 years old.
75, the uncemented.
So above 75, it is all will be cemented, not uncemented.
So that's maybe your choice, yeah, absolutely. But just try to find the NGR data about what is now the commonest implant used in the NGR data. Is that okay?
Yeah.
Sorry, but the exam answer is still cemented implant. Exam answer is not uncemented.
Okay, thank you.
Okay, so just be careful about that. Anyway, just I will get, this is a case come to the consultant, and the consultant discuss exactly as you said. This is a very complex situation, and the sciatic nerve issue, lengthening, and you need to be afraid. And then the patient said, I will manage with a shoe lift, and he's managing like that. So that's very good. But just and divide your answer, try to signpost your answer. This is a pre-operative template into operative. I would concern it post-operative. I will be concerned immediately early late. Just structure the answer. Take a deep breath. Guys, whenever we load the computer takes some moments loading. We need to do some sort of loading. This loading time, you just restore your algorithm to the answer. Okay, don't let anyone try to move your shake your confidence about your answer. Okay, now the second case scenario, but that's very good, Rami. Just carry on and try to avoid any kind of controversy. Is that okay? You agree?
Thank you very much. Thank you.
Chuan, you are muted.
My apologies. Yes, absolutely, I agree. Rami, you really well done. That's really well presented thing. Just the small tips that we're giving you, and you will do really well with that topic. And using the algorithm that Walid is showing you is perfect. Well done.
Thank you.
Okay, so this case, I will choose another one if there is any volunteer.
Sam is next, Walid, followed by Alan, and then finally Mitwalli. So
yes, okay.
Okay, so this is 64 years old woman who presented to ED with painful left hip. Okay, so she had a hip replacement. She mentioned, by the way, sorry for that. As a comment, Rami, when I'm not sure about skeletally mature and immature, because I never find anyone when we are in the trauma meeting. This is a plain radiograph skeletal. When someone give you a history, this is a 46 years old who presented in the clinic, have this hip. When you say that I can see a plain radiograph skeletally mature, I'm not sure. And I used to say it.
Not necessary. Yeah.
Sorry.
It is not necessary in.
I'm not sure. I don't know what is the rest of the mental opinion about that. When you say to use, he's a 46 and he's in the clinic and he had this painful hip. When you say I plain radiograph skeletal mature individual,
depends. Walid, exactly as you said. If the person's telling you it's 46 years old, then you don't need to say skeletal.
Yeah. So it's a plain. Yeah.
If this an X-ray without mentioning age, then skeletal mature or immature is appropriate, I think.
Yeah. So you say just this is a plain radiograph. EB view of the pelvis of this individual, of this patient, showing overall diagnosis. On the acetabular side, I can see. On the femoral side, femoral head joint space, proximal femur, I need to see a lateral view. My concern about my differential diagnosis like that. Okay, Hassan?
That's a very good point, Walid, because there's marking now in how you're focused on listening to the examiner. In the marking sheet, the data that the examiner gives you, if you didn't listen to it fully, they underscore you. So you have to listen to all the given stuff that he gives you, and you mark on it. Okay.
Okay. So this is as you can see, this is as I mark it is an ED setting, and this is lady is a 64 woman presented to ED with painful left hip. She had a left hip replacement that's done 6 months ago. And she is now in the emergency department. Tell me what you are going to do.
Yes, first I'd like to describe this is AB radiograph skeletal female with showing this completely dislocated left hip, left
You
total
said
hip,
skeletally mature in
skeletally immature female with left hip dislocated, total hip replacement. I'd like to ask questions about the history. Is there any history of infection, any history of pain, fever? What is the cause of the index procedure?
Mhm.
And I'd like to know the post-op report. What is the procedures used? What is the cause for doing this surgery? And
She doesn't know anything about the prosthesis. She went to a good doctor, and the doctor he's very famous guy in our area, and he put this hip for her. She doesn't know anything about the prosthesis.
okay. Second thing, I'd like to know any the past history of the patient, what he was complaining, what is the medical conditions he was suffering, why she did this operation, and if she received any previous treatment for her. And I'd like to know any associated comorbidities. What is expectation of the patient? What is I'd like also to know what is
So expectation. She's in ED at the moment. She's screaming.
yes. So first of all, I'd like to assess, assuming there is no history of trauma.
No, so she was trying to pick the postcard from the from underneath her door, and she just get out and she sat on the floor and she called the ambulance.
Okay, and assuming that ATLS protocol has done and patient only has this problem, I'd like to assess the patient.
So do you think that condition with this very low energy twist will be associated with needs at ATLS?
I cannot guarantee it can be fell down. She has any head trauma, anything else.
She doesn't any of those.
Okay, that's to exclude be safe for the patient. I'd like to next. I'd like to assess the patient, check neurovascular status for her, if there is any sciatic problem or sciatic compression for her. It will be painful for do any examination. She will give analgesia before. And I'd like to see another view for this patient, lateral view.
Okay, that's the view. As you can see, she is really obese lady, and that's why even the X-ray profile cannot get both hips. So, and this is the only view available.
Okay, and I'd like for any signs of infection, any signs of swelling.
How to know that?
I'd like to all the scar of the previous operation. And
okay,
so
it's a THR 6-month scar. Good.
Okay, so I exclude infections and there is no fever for her.
No, she doesn't have fever.
Okay. After that, I'll try to do close reduction in ER. If not came, I'll discuss. This is complex case. I'd like to discuss.
How would you do this patient in ER?
I'll introduce it in traction with lateral traction.
So
with someone supporting the pelvis for me, and I'll do longitudinal traction with lateral traction of the.
Okay. So I will stop here. Okay. So first of all, whoever is that's I wouldn't say good, and I wouldn't say you are a very practical person, but just that you are assuming a lot of things. The examiner will stop you at every single question when you say, I need to exclude infection history. Patient is screaming in ED. So just try to be a bit slicker, and that's something just I have been told how to answer this question from real life scenario. So patient presented with dislocated total hip replacement. First of all, I'll describe this X-ray. This is a plain radiograph EB of the pelvis showing a hybrid hip replacement with a dislocation. Can be anterior or posterior dislocation. The position of the acetabular cup looks a bit closed. However, I need to review another X-rays. And there's I cannot comment on the femoral inversion. So that's very first full description. So the thing, I will do my assessment by history, examination, proper investigation. My aim is to reduce the hip initially and looking for the cause. That is the first opening statement in hip dislocation. So you mentioned to the examiner, and in the trauma meeting, that's what we do. We reduce the hip, we discuss in the morning, or if we manage to reduce it, we reduce the hip, and then we discuss with one of the senior hip surgeon Why do you think this lady have a dislocation? Okay, then you in the history make it flow and the categories. I will ask about the dislocation. Then I will ask about past hip history. One of the causes, whenever you read in any book, you will find he mentioned to you causes of dislocation: patient factor, surgical factor, a surgeon factor, implant, a primer arc. All this is lovely stuff. However, in the exam, he wouldn't go through that thing unless you are in the basic science or there is something obvious in the X-ray. So I'll say, I will ask about the past hip history, including the total hip replacement, indication, duration, preoperative period, outcome. Because if one of the indication may be a fracture nickel femur mesh, you might have that from fracture nickel femur. And we know that the fracture nickel femur have a higher rate of dislocation. History of this and the surgeon. I will ask about the surgeon. You might have a surgeon who is well known to have a high dislocation rate. So you ask about the surgeon. Then you ask about instability. Any instability, Then I will ask about other joint history. Then I will ask about past medical history to look for the patient risk factors that can be a patient biology or patient mechanics. Patient biology, I will ask you, patient biology is a brain, stroke, Parkinson, coda equina, nerve entrapment, muscle atrophy, tendon bone injury, any of those. Then, or spine biomechanics, the patient may tell you, I have a big spine surgery, I have a fusion from L2 to S1, for example. Like these cases, we saw them, we just discovered them on the X-ray in the meeting. You find the rod coming from the bottom of the spine up to the sacrum. So you ask about this history, then I'll do my examination, looking in general for observation, because, and that's relevant because the patient in the emergency department. And then local, as you can see, I left these slots empty because I cannot walk the patient, I cannot move the patient, I cannot stand, I do nothing. I'll just look for the limb position, skin scars, and I will assess the neovascular. Okay. Then my investigation, initially in D, I'll obtain plain radiograph, check previous radiograph. Then I will do CT scan. Most of us don't do CT scan intraoperative. Sorry, in ED, we do that after we use the hip, after the storm pass. Then we do this kind of investigation for definitive. Then we do bloods as any patient come to ED, and then we do inflammatory markers to exclude infection. Then you say my aim of treatment, initial, I would use the hip under appropriate analgesia. We don't take people to resus and just to do traction of the hip. What we do usually, I will tell you what happens in ED, and that's the difference from hospital to hospital, but just you have to say it. You will take the patient, you will mention the emergency department will call you have a hip dislocation. You have a look at the prosthesis, because I will show you some now case, a real case scenario. You will see, look at the prosthesis, and then you say to them, yes, you can reduce it, or I'm coming to reduce it. They have someone who is going to administer some sort of diazepam or propofol or whatever, or ketamine, maintain a way, maintain the patient to monitor, and you will come with your assistant or the nurse from ED and reduce the hip. That's in a simple hospital like our hospital. Then you will say this is the initial treatment. Then you will get a check radiograph, re-examine the patient. I will document my findings. Then my definite treatment will be, I need a pain-free, stable hip. Stable hip is very, very essential because you need to eradicate instability. Then you will mention about non-operative and operative treatment. There is nobody mention instability to be non-operative unless the patient had comorbidities or patient refused surgery or have a complex issue. And then you mention about what intervention, what's the outcome. And then you mention about the pre-operative challenges, intra-operative challenges, and the post-operative challenges, okay? And this is the pathway how to go through it. And the buzzword when you say pre-operative planning, I am thinking about the bearing surface, either to use a large diameter head or dual mobility to increase the safe range of movement. You say this word, to increase the safe range of movement, or decrease the unsafe by using constrained couple. To decrease the unsafe range of movement. And on the femoral side, I will restore the offset, the version, the length. On the acetabular side, I will use the abduction angle, the version offset. Okay. When you have this simple pathway in your mind, when you come to a more complex case like this one, for example, this patient came when I was on the weekend, on Friday, couple of Fridays, past Fridays. Patient had a dislocation. So if we ask, Shwan, can you choose someone to start talk about this one?
Alan, you're volunteering, Alan.
Any volunteer?
Yeah, thanks. Yeah. Yeah, can you hear me?
Yeah, Shuain, yeah, I can hear you.
Yeah.
Who's that?
You have
Ilan, yeah.
Hi, Ellen, how are you? So
Yeah, good, thanks.
72, and she came to ED with painful right hip.
Okay, I can see a plain radiograph of a pelvis with both hips showing bilateral total hip replacement prosthesis. The right side shows a dislocated hip prosthesis. It is a hybrid construct with a cemented stem and a uncemented acetabular component. And it seems to be like a constrained liner has been used on both sides. And the right side cup inclination seems to be slightly more increased compared to the left.
Okay. So she's in ED.
Yeah. Okay. So I would like to know the history when the surgery was done and what the indication was.
Okay.
And, yeah, and whether she had any history of trauma prior to this.
Yeah, so she had a twist of her hip, and she had multiple surgeries before.
Okay, so I'd like to know when the surgery, how many years back the surgery was done.
It was the last one in
2018. Sorry?
In 2018.
Yeah. Okay. So I'd like to know the post-operative period, whether the wound healed uneventfully, and following that she was asymptomatic all this while.
Asymptomatic from what perspective? The wound healed very well.
Okay. So I'd like to know the medical history, whether she has any neurological conditions like Parkinsonism, because considering the fact that they've used a constrained line, I would like to know the history why.
No, she doesn't have Parkinson's.
History of diabetes, any regular medications like steroid intake?
No.
We'll stop there, Ilan. Do you see how you're getting yourself into trouble here? Have you noticed what's happening? And this is, I'm really glad you're showing this, because it really gives an opportunity for us to address this. This is what we're talking about in terms of your flow and your ability to logically move through the questions. You've now started to interrogate the examiner with, has the patient got diabetes? With it, and all the examiner does is yes and no answers. Rather than the appropriate way to ask these questions is, I will assess the patient for any comorbidities that would indicate higher risk surgery, including previous histories of infection, diabetes, muscle patterning problems, and or multiple surgeries in this case, and sorry, my apologies, history of stroke and other cardiovascular problems that may affect the anesthetic, as well as the musculoskeletal patterning here. Okay, just very simple, broad phrases, and I'm not even practicing it myself properly. I appreciate that, but if you're going to spend the next 5 minutes saying, has the patient got diabetes, has the infection, how many surgeries, when was the last surgery? Because every time you ask that, the examiner is going to pause and think, what is the guy is asking me? He needs 10 seconds to think about the answer. And now you've wasted 30 seconds each time. Does that make sense?
Yeah. Thanks. Yeah, I get it.
The pathway that Walid is showing you is hopefully going to prevent that. And thank you for volunteering, because you are demonstrating to us why the importance of this pathway. And what is interesting about Walid's pathway is, if you notice, it's really big, and there's no way you could go through that entire pathway right down to revision surgery unless the examiner stops you off there and says it's been reduced, and let's talk about what you see as the problems. Could I also point out that I'm not 100% sure, but I don't think anyone picked up the particulars of those x-rays from the beginning. Yes, we tell you, look at the x-ray, spend 30 seconds on it, but there are some very important particulars in both x-rays. There was in this one, That's a capture device on that hip. Do you see that? That's because this patient has had multiple dislocations and or has muscle patterning problems that may increase their risk of dislocation, and therefore has been given a capture cup as their first surgery, or this is a revision surgery. Does that make sense, guys? Second, I'm worried looking at that x-ray straight away. First, you correctly said the cup is open compared to the other side, but you'd like to look at the previous x-rays to reassess that. But I'm worried of the femur, because the femur looks like as if there is a poor cement bone interface and the joint space or the effective space has increased significantly. And that might be a loose prosthesis. So already this is a highly complex case, and this is not going to be managed in A&E in any way whatsoever. I appreciate you were coming to that, yeah, but you were never going to get to that point of conversation if you were doing that interrogation of the examiner. Does that make sense?
Yeah, I get it. Thanks, Ron. Yeah.
And if the previous X-ray, that's not a normal dislocation if you look at that previous X-ray. So anybody who deals with, like us, deals with these cases on a daily basis would recognize that that pattern is not normal. That normally when a hip dislocates, the adductors and the abductors are tight and pulls the hip in. So the head is resting on something, not, this one is not. So either there's a muscle patterning problem here, or the the abductors, adductors, the soft tissue envelope is really disrupted, badly disrupted, that there is no tension on that. Or there's a neurological problem here, or a muscle problem here, okay? Does that make sense, guys? Recognizing that on the x-ray is far more important than the spiel of this is a 65-year-old with a 64-year-old with a total hip dislocation, cemented prosthesis with an uncemented cup, cemented, and that's, there are some relevant points on these x-rays. So do take advantage when you spot those cases. That's where this question is going usually. Examiners will pull you back if you're wrong. Don't worry.
Perfect.
Sorry,
Thank
do you agree?
Yeah, that's very good. So that's a very complex problem. This case have been discussed twice in Southwest hip meeting with extra guys, and they said this is a very complex situation. You have to just mention about your initial treatment, you recognize the causes, and then the complexity of the case. You do pre-operative workup, you do the imaging and lab, and then you discuss with the senior guy, optimize your patient. And then the general principles: increase the safe range of movement using the large head of dual mobility, or decrease the unsafe range of movement by doing a constrained cup, and obtaining on the femoral side, right version and offset on the femoral side, obtaining your abduction angle, and prior to all is optimizing the patient. And in extra, they suggest to use a dual mobility for this patient anyway, and physio. So have a look at this one. I just need to draw attention of this one. You might find that in ED. Okay, and the examiner will bring it a hip dislocation. Please, that had been reduced, taken to theater, reduced in this position. Anyone recognize anything which looks odd? So when you see a big cup like that, and the small head that doesn't look the right thing, and it had been reduced, when you see the reduction, it is reduced as clock and it is N, but it is not centric, okay? And when we did a CT scan for this patient post reduction, because the patient cannot walk even, we find here something is resting here. This is the plastic of the dual mobility. So you can have any of those, okay? And that patient had a revision, just a revision for the plastic insert in the dual mobility. Just pay attention to that. You may have a simple, you may have a dislocated constrained cup. So constraining, it doesn't mean it doesn't dislocate, it can dislocate. Dual mobility can dislocate, and then you find a centric reduction. You will confirm on CT scan, and the same principles. We did the same workup, complex case, discussed with a senior hip surgeon. And most of these cases now is two surgeon operating. Okay, so that's as regard the one complex hip case and the one revision complex case. The other case which I would like to discuss is this one, shall we bring someone to start talking, Shwan?
Yes.
Mitwali, you next.
Please, who's our next person?
Mitwali is our next person.
Thank you.
Yes, I'm here.
So she's 70 years old lady who had a severe left knee pain for the last 3 years.
Yeah, the first photo showing clinical photograph of patient standing. There's severe valgus deformity of the left lower limb at the level of the knee joint. I cannot comment on if there's any scar, apparent scar or not on both sides, but
No
the skin
scars.
on the X-ray, I see advanced osteoarthritis of the knee joint with severe arthritic changes on the lateral compartment. I feel I am not sure from the X-ray, it's too small. Is it has unicompartmental knee on the medial side, or this denotes laxity on the medial side of the knee joint? But I'm not sure from the X-ray.
So I don't know. It's a what do you think? What's your thoughts? What's your diagnosis?
I feel it's primary osteoarthritis knee with valgus deformity of the knee joint.
Good. So this patient have pain now for her knee for the last 2 years.
I need to take the history regarding the patient's symptoms, how this pain affecting the quality of life, and I need to also the comorbid conditions, how the ambulatory status of the patient. Then I need to examine the patient to see his gait, if there's any thrust during walking, has any limping, she's using any assistive walking aids.
Okay, so she's limping, and she's using.
Then I need to examine to assess if the reducibility of this valgus deformity is reducible or not. How the patient, the flexion extension range. I need to assess also the neurovascular status of the limb.
Okay. So that it is unstable knee. There is no. The valgus is partially correctable, and there is severe instability in terms of her MCL examination.
There's instability of MCL. Sorry.
Yeah. What do you think the MCL looks like here?
It looks insufficient because the medial joint space is gapping too much, with the lateral side is almost bone on bone.
Okay.
I will counsel the patient if the non-operative measures are exhausted. I will counsel the patient for the possibility of total knee replacement.
Okay. Do you want to do anything before all that?
In valgus knees, I need to do CT scan to assess the bone deficiency of the lateral femoral condyle.
Okay, you did the CT scan. There is no much bone deficiency. I will ask for X-ray for the ipsilateral hip to see if there's any associated prosthesis of the same side. So you get a full length femur, and there is nothing above. Yeah, good.
Yeah. Then I'll ask for a lateral view of the knee, of the ipsilateral knee, lateral X-ray view.
Okay, good. You get lateral, doesn't show so much. Okay, good, Muhammad. So why Bitwali, sorry. So why do you think I put this case? Because it's a very common case. I think I have exam experience on my file since 2008, and almost always I find this coming every time, the valgus knee or complex knee. Okay, because it's a common case in the exam and real life. Okay.
Yeah, because it's common, this valgus deformity with osteoarthritic changes with no osteophytes is most probably rheumatoid or inflammatory arthropathy.
Okay, so when you come to a case like that, so I just give you the pathway to. So first of all, you have a severe valgus knee, and now agree that we are coming to this knee to discuss take eye with the challenge, because usually they get this case as a short case to ask about what prosthesis you are going to use, or they bring this as a Viva table and they ask you how to assess this patient. So you, first of all, you describe the X-ray. So then you say this is a valgus osteoarthritis knee with a predominant degenerative changes in the lateral compartment. Medial compartment is opening. I'm concerned about insufficiency of the MCL. That I need to know the underlying cause of valgus. Is this a primary osteoarthritis, or the other causes can be inflammatory arthritis, post-traumatic previous meniscectomy, or a previous meniscectomy. I will do my assessment by take history, examination, investigation. History of the present complaint, ensuring the pain originating from the knee, and the history of red flags, suggestion, serial pathology. I will do an Oxford knee score. What treatments received? What's the outcome? Then I will ask about past knee history, including history of trauma, treatment. I will ask about other joint history. You say ipsilateral hips. That's absolutely right, because if we have a long hip prosthesis coming on the way, if you use any stemmed implant, that will be an issue. I will ask about medical history. How fit is the patient? Any history of inflammatory arthritis and the comorbidities. My examination, looking general for BMI and the general features suggesting inflammatory arthropathy. Local, I'm looking for the alignment, looking for the gait for any thrust. I will examine the extensor mechanism, patellar tracking, tenderness and diffusion, fixed flexion deformity, stability, correctability, and the MCL insufficiency. I will finish my examination by examining the hip, spine, and the knee, hip, spine, and neurovascular state. My investigation, I will go to the lab. Imaging include graphs of the knee, including full weight bearing for views, and I will obtain a long leg alignment. It's a complex case. You need to know how much is alignment. I will get a CT scan if I have a concern about it. Then you say bloods, which is basic bloods, and cross match if I think about surgery. What is my aim of treatment? This is a complex case. This is very complex. My aim of treatment, any intervention, is to improve the patient quality of life. I need to achieve a stable knee, restoration of the joint line, coronal alignment with balanced gap, and the normal patellar tracking. The guidelines is nice guidelines about primary joint arthritis. The principle, this is a complex primary knee replacement. I will do my intervention is take our outcome of the 90% survival up to 15 years. The general principles, I would say pre-operative, intraoperative, and post-operative. Complex case, I need an aesthetic assessment. I need a senior hip knee surgeon to get it right first time. And I need to do pre-operative planning for the MCL deficiency. If this is completely deficient, I will use a condylar constrained knee. If it is completely lax, I will use a rotating hinge knee replacement. And other specialties, according to the input, the consultant, or so not the consultant, the examiner will give you. He might still tell you this patient is a rheumatoid arthritis, or he may tell you it doesn't have rheumatoid arthritis. So you need to involve some sort of rheumatologist or to check for medication and things like that. Then you divide my intraoperative, including the exposure, the femoral side, the tibial side, and the soft tissue. And then post-operative, this patient has a higher risk for common peroneal nerve palsy, prolonged rehabilitation, and I will give her routine post-operative thromboprophylaxis. Just to show you what we do for these cases. This is not specifically this case, but this case from our hospital. So just for everyone, this case had been listed as a complex primary knee replacement to consultant surgeon. So it is not something like say, I will do that, I will do that. No, that's something you will refer to, and both of them are specialist knee surgeon. Have listed here to a complex case. They have an extra time for operating time and 2 consultant, and they put at the end for her a hinged knee brace. This is a prosthesis, a rotating hinge knee prosthesis. Okay, so just try to, when you are going through it, don't stop, please. This is part of the story. So when you ask, I give you a valgus knee. Now you know I'm going toward a valgus knee. Give me a bulk of question: history of present complaint, past knee history, past medical history, other comorbidities. I will do examination. Try to remember. I feel the most important, if you get just out of my talk, red zone. The red zone is the zone which you need to hold yourself to ask a specific question quickly and wait for the answer. Yellow, this blue zone, which is the examination, try to mention bullet point what you are looking for. Valgus knee, everyone looking for a certain point, 5-6 point. Investigation, lab and the image. Once you come to green, take a deep breath. My aim of treatment, the guidelines, the principles, the options. And then you mention the challenges in a very simple way. It's not necessarily to go in depth in these details, but just to mention the anesthetic, I need optimization, senior knee surgeon to review the case, and other specialties if someone needs to be involved into operative, I will do that. If you mention there's the first line, the examiner may be happy for you to tell me more why you want a senior knee surgeon to do that. Yes, because these cases are more liable to like that. Okay. I think it's 9:10 now, so I take almost 1 hour 20 minutes. So I will stop here. Is that okay? Ishwan,
yes, that's. I think that is a very reasonable. Also, I want to say thank you, Walid. That is excellent talk and an excellent logical sequence of the way to go. And I love the way you've done that flow chart. We've been saying as mentors all the time, prepare your answers. These are straightforward, give a few points on each one. And you've demonstrated that beautifully and how it can be done rather than long lists of words and writing. It's because the knowledge is there. All you need is reminders, memory.
Yeah, that's it. Yeah, exactly. You just need...
Also the actual pathways creates that logical thinking and the higher order thinking that is required for this exam.
Thank you.
Well done. And thank you to all our participants. Really well done, everybody. You are coming on in leaps and bounds. I'm really proud of you guys, and also really proud for volunteering for these talks. Well done.
So guys, I'll be sending you feedback to every email registered. Okay, so I'll be really grateful you can reply to that when you get the email. Is that okay?
Okay. Given today has been a kind of practice Viva session, but in a more formalized format, we will stop today, and Walid will hopefully come back and present another session. It looks like we can actually go a little bit more because I suspect you have a lot more lower limb as well as upper limb. So we're going to exhaust you, I'm afraid, Walid, by the end of this. But I think what you're doing is really valuable, and this is quite a useful format. So please do fill out Tamir's feedback forms, because it does help us know how much more what we can do to improve this format as well, because I think that's a format we will use a bit more in the future as well. Thank you, everybody. If there's no questions, I'll stop the recording now.